Now we are open. So it's my honor and privilege to introduce Dr. Luis Guzman. By this time, you may know he is the first course director in Bangladesh 2019, and he was the that time international program committee chairman. And we are really happy during the long COVID. We just uh, suspended our program for 2 years. After that, we again reopened it. And today it is our third Sky Bangladesh program. He is the keynote speaker today's session. Please come and give your keynote speech. Our today's theme is HTMI care should be enhanced in Bangladesh perspective. That's why we designed our session mostly HTMI based in terms of other complex coronary artery procedures as well. Thank you very much. Please. After that, Nur Alam will take over the session charge.
So while we are getting the computer ready to start, I want to thank the organizers as well as all of you guys for getting the time to be part of this educational activity that I do believe that is going to be very exciting, but also, okay, all right, okay, I think I need to. But also demonstrate the continuity of education that we have started in 2019, and we are committed as an institution, as a society, to be part of your education. I don't know why this computer goes on its own, but so I will start. So I will get you to a journey about ST elevation myocardial infarction, and as you know, this is probably, I don't know why this computer is advancing on its own. I didn't pick any out of place, so can you see why? It is there. Let's hope that it's not going to go on its own. Okay. Yeah. So we all know that this is the #1 reason for mortality in most Occidental countries, industrialized countries, and I'm pretty sure that here is going to end up being also the #1 reason for mortality and tremendous expenditure in the healthcare system. And part of that is as a consequence of us, our lifestyle. So this is a grill near a hospital that is called the heart attack grill. And they have the triple bypass cheeseburger, and you can see this is part of what we do. We know that we can use statins, we know that we can use blood pressure control, but lifestyle modification is probably one of the most important ones. The second one is smoking. As you can see, people that smoke live an average 12 years less than people do not smoke, and this predominantly is as a consequence of cardiovascular disease. And the third one is the lifestyle and stress that we are exposed during our life. And in order to represent this stress, I chose this article that I know that you guys are very fan of soccer, so cardiovascular events during the World Cup. And as you know, I am from Argentina, so we won this one, and we just won last couple of months ago. We are very happy about this. But if you look at this study, you see that this study that they checked the number of people with cardiovascular disease 2 years prior to the World Cup, and then they look at the year of the World Cup. And you see here, you see that this is number 6, the peak of more mortality, more cardiovascular events in Germany during the World Cup, and it was Germany versus Argentina. So we always say that we took care of the Germans in a different way. So for you to understand, I just give you this video to see what is the meaning of why we are so fanatic. So this is last World Cup in my house. This is me sitting in there, and this is when they were ready to kick the last penalty kick. and you will see the faces of the people and how everybody is so desperate, and you can understand why the people, unfortunately, you cannot hear this, but here we go. And then everybody was so, before that, I was not able to see the TV. I just saw the TV when the people started to scream. So probably the French kill more Argentinians than we kill Germans. Anyway, after that, I was able to pull my jersey, and that was a good thing. So let's go back to science. So that is what we did in the past. So complete, sustained, and early revascularization, and there were all these debates about whether one is better than the other one. I think the debate is over. If you can have a PCI, PCI is better than lytics. I think that it is not part of the discussion any longer. So, but we do know that the sooner we go, the better it is. This is with thrombolytics, the golden hour. So if we do reperfusion very early, we do have a reduction in mortality by 80 to 100%, whereas if we go after 4 hours, that reduction in mortality is still there, but as you can see, very minimal. So the early we can reperfuse, the better. So the paradigm shift over what is the best reperfusion therapy to the treatment of try to decrease the time to get this therapy. And I know that this is a kind of old slide already, or old topic already, but I'm pretty sure that here in Bangladesh you are still dealing with how to achieve this better reperfusion time. So you know that door to balloon is associated with mortality or survival over time, more significant so in those high-risk patients than the low-risk patients, because the mortality in the low-risk patients is lower to begin with, so we will not make that much of the impact, but certainly will make an impact in heart failure. So how to manage this? And I just want to give you our way of dealing with this problem, and it is a system-based. If you do not have a system-based, you are not going to be able to do this. A system-based that reperfusion therapy in MI involve all the different players. So this is the goal, and if you see the variation on the time to reperfusion is almost 100% related to whether we have a system that takes the patient sooner to the cath lab. So we review our process, and we saw that we have a lot of different steps prior to get the patient in the cath lab, and you can see 35 minutes to do an EKG and 72 minutes to activate the team. That was when we started. That was our reality. If you do not look at your reality, you will not realize what is your reality, and you will see that it is true that it takes a long time. So this was the goal, 10 minutes to EKG, no more people involved in anything, no even a nurse. The patient comes with a chest pain, and they do the EKG, and the EKG show to the doctor. The doctor activates the STEMI if there is a STEMI. What happened with that? If you see here, door to EKG, EKG to activation, all those one went down, and we almost decreased by 80 minutes the amount of time that took for those patients to get into the cath lab. But that was not only that. The system also tells us that if you do field EKG, this improves a lot. I do not know what is the possibility to have it here. I suppose that there is possible. And if we do that, certainly the EKG is transmitted, and then in less than 5 minutes, we know there is a STEMI, and this decreases the time. As you can see here, just to have an EKG transmitted to the hospital decrease the average first contact to the patient to balloon by 15 minutes, which is a very significant decrease. Importantly, I don't know how often this is used, but CT scan of the chest for patients with chest pain, if they have a STEMI, do not help at all. So I hope you do not do that, because increase the time by 75%. What happened when we did EKG in the field? As you can see, first medical contact to balloon decrease, and door to balloon decrease dramatically. But more importantly, you see that there is not much that we can change in the cath lab. When we do our job, no matter how better we want to do it, we do not change too much. It remains very similar. So it's prior to us getting involved when this is going to improve. The last one is to activate in the field. And if you see, this is another task because we have to train the paramedics to do that. But when we do that, we decrease even further. And if you see here, if the patient was activated in the field, how much we decrease. Again, no decrease almost at all in the work that we do ourselves in the cath lab as an interventionalist. Is a system-based change. So the last one is hospital transfer, and I will not talk about this because I think this involves a lot of local decisions, so I will not get involved myself in this local decision, but hospital transfers are important. So where we go from here, the future. The future is try to decrease further long-term mortality, no 30 days mortality, which is what we do initially, but also decrease this epidemic of heart failure that we have as a consequence of the saving this life, but having the heart damage. And lastly, improve cardiogenic shock mortality, which all of you know that we haven't made too much of the improvement on this. I will not talk too much about, I will not talk about cardiogenic shock, but it's because there is a whole session about that. But I will tell you that the only way to treat these patients with cardiogenic shock is with shock team approach. Again, myocardial infarction is not a single doctor care, is a lot of people involved in the pre-medical evaluation, in the pre-system, in the emergency room, in the cath lab, and after the cath lab. So how do we increase mortality? We know that infarct size correlate with mortality and correlate with heart failure at 1 year. This is a pool analysis of 10 randomized clinical trials, and if you see, the larger the infarct size, as is the higher the mortality of these patients on long term, as well as hospitalization for congestive heart failure. So by average, an infarct size by MRI is 18% of the myocardium. So if we increase that, we have much more mortality, and is stated by every 5% increase in the infarct size, there is a 25% increase in mortality and 20% increase in hospitalization for heart failure at 1 year. So how we went from decreasing ischemia time to try to prevent what we call reperfusion injury. You know that prior to thrombolytics, the damage of the heart was secondary to all ischemia injury. When we use thrombolytics, we do reperfusion, and then we decrease the ischemia injury, but we start to have what is called reperfusion injury. When we do balloon angioplasty with timing reperfusion, we decrease the ischemia injury a little bit further, but the reperfusion injury remains the same. So our challenge for the future is maintain our low ischemia injury time, but decrease what is called reperfusion injury. So why there is reperfusion injury is because when the artery is occluded, the mitochondria remains stable and nothing happens. When we open the vessels, the mitochondria produces changes that increase the influx of calcium, and the mitochondria is now programmed to kill the cell, either necrosis or apoptosis, and that produces more damage. So how we can decrease that is our new target. We do know also that there is what is called microvascular obstruction. So this is an MRI of a patient with a heart attack, and if you see here in white is the area of the myocardial infarction, but this is after reperfusion. This area is getting appropriate reperfusion, but this area in black is an area that's not getting any circulation. There is microvascular obstruction, and we can quantify that, and when we quantify that, we can see there is a very significant association between the area of microvascular obstruction and the development of mortality and heart failure in the long term. Importantly, there is no incidence on recurrent myocardial infarction. Neither reperfusion injury nor microvascular circulation has nothing to do with stent thrombosis or new coronary events. They have to do with the myocardium that has been damaged on day one. So for it is based on studies, there is an increase in 15% mortality and 8% heart failure hospitalization for every 1% increase in microvascular obstruction. So actually, if we see there is a very close association between microvascular obstruction and infarct size and long-term outcome, almost identical number of mortality at 1 year as well as heart failure at 1 year if those ones that they have higher infarct size that also correlate with with microvascular. This is similar to what I just said. If you have an infarct size that is more than 18%, which is what we call cutoff, you see that the mortality is much higher than if you have a smaller. But if you see that if you did have a myocardial infarction that is large, but in addition to that, you have microvascular obstruction, your mortality is also significantly higher than if you didn't have it. So there is an association between both. How we can decrease microvascular obstruction as well as reperfusion injury? And there is a lot of evolution in technology to do that. We know that pills do not work. We have tried many reperfusion or anti-reperfusion injury medication that has not worked for the last 25 years. So what about intracoronary local activities? So intracoronary hypothermia is some of the things that you will be seeing in the future. It's already approved in the United States. So trying to get the temperature several degrees down prior to opening the artery has been associated with reduction in infarct size. If you see here, this is a proof of concept. First 100 patients randomized in intracoronary hypothermia. It did not produce any increase in new problems for these patients, so the larger randomized trial is being undergoing at the present time. Another way to do decrease reperfusion injuries, unloaded the ventricle. This is another theoretical benefit that has been under investigation. Why is that? If before we open the artery, we try to decrease the LVDP, we will decrease wall stress and oxygen consumption, improve in that way tissue perfusion, and activate signal pathways of cardioprotection. So by doing that, the goal is to decrease reperfusion injury. And if you see here, this is the first 50 patients randomized to delayed reperfusion versus opening the artery. So reperfusion is delayed for 30 minutes. So we put the impeller into the LV for 30 minutes before opening the artery, and then we open the artery versus those ones that have immediate reperfusion. And if you see, even though mortality was the same, infarct size was diminished as well as microvascular obstruction was diminished in half. So even though this is not something that we are ready to do, there is a larger randomized trial that is trying to evaluate this in a large myocardial infarction patient. So the other technology that we have is supersaturated oxygen therapy. So we are infusing in the patient blood that it has a lot of oxygen in a way. So there is experimental animal models that they show reduction in endothelial cell edema, induce capillary vasodilatation, and limit infarct size. What happened in humans? So basically, the first group of patients that were done, we see that the infarct size at day 5 on MRI is actually lower than the average that we've seen. But look at 30 days, it continues improving. So again, proof of concept, and there is a large randomized trial. So this is a smaller trial with 83 patients that were treated with supersaturated oxygen, and compare with the equivalent group of patients from another randomized trial. And if you see, there is a significant decrease in mortality and heart failure hospitalization, no changes in ischemic event, not expected, and if you see mortality and heart failure. So again, a proof of concept that is being evaluated in large randomized clinical trials at the present time. Last one is how we can prevent microvascular obstruction, and in some patients, delay stenting may be something to consider. This is a patient that came with an acute myocardial infarction. As you see, right coronary artery occluded, we pass the wire, we do a little balloon, and you see that the artery is not very good and the distal TIMI flow is not that good. So after that, I did aspiration, thrombectomy with mechanical aspiration because there was a lot of thrombus, and then balloon it and stent it. And this is what happened after the stent. So after the stent, we have no circulation whatsoever. So this patient, no matter what we do from now on, intracoronary vasodilators or anything that you wanted to do, the damage is already created. Even though we are going to get a better TIMI flow at the end of the procedure, this patient highly unlikely will improve his left ventricular function. So this patient probably, if we try to avoid doing stenting at that time, will probably the best thing for that patient. Just reestablish flow and just wait. This is actually a study, a pool analysis from several thousand of patients that they look at the presence of TIMI2 flow after balloon large thrombus, and you see if the patient were not stented at the time, they were associated with 5 times improvement in TIMI3 flow, TIMI blush, ST resolution, and significant decrease by 50% in MACE if they were treated more conservatively. So something to keep in mind. So to summarize, early reperfusion remains the main objective of patients with myocardial infarction. Community-based systems should be developed in order to perform timely reperfusion. Goal should be door to balloon less than 60 minutes and first contact to balloon less than 90 minutes. Patient with early presentation less than 2 or 3 hours. The fastest available therapy should be the treatment of choice. Patient presenting after 3 hours, in my opinion, primary PCI is the treatment of choice. If you decided to do thrombolytics as initial treatment, these patients should be considered to be transferred to a PCI center. The timing for PCI after lytics appears to be between 3 to 18 hours. Long-term mortality and the epidemics of heart failure post-myocardial infarction remains a major challenge. Dedicated therapies to decrease infarct size and prevent microvascular obstructions are under evaluation. Cardiogenic shock patients should be evaluated and treated by a team approach following standardized protocols. Thank you very much.